Good evening, everybody. I am Lauren Wilfling. I'm the Education Commission co-chair for MAFP, and I am going to be the moderator for tonight. We are talking about value-based care for the family physician with Dr. Kate Lichtenberg, who is here with us. I was really glad to see they didn't include her whole CV on this introduction because that would take half of our time together. Needless to say, she's qualified, and I'll let her get more into that when it's her turn. But tonight's presentation is going to be delivered live, and Dr. Lichtenberg will be available for questions following the talk. Feel free to drop questions into the chat window as they come up during the presentation, and I'll moderate those at the end. But you're also welcome to speak up and ask your questions directly at the end of the presentation as well. Just a reminder that participation in tonight's presentation qualifies for 1 CME credit. It will be recorded and uploaded to the MAFP's YouTube channel for future reference, but in order to claim the CME, you do need to be here for live attendance. So to get that, please complete the short survey at the link that Bill sent out in the registration email. And the reminder email, it will also be dropped in the chat towards the end of the talk. So click on that when you can and give us some feedback to let us know how you liked the talk. And then that information will be used to report your CME to AAFP on your behalf. Just a reminder, this is the 9th of 10 sessions that the MAFP has planned this year for our interactive CME. We have one more session that I'm really excited about on October 17th, which is about primary care dermatology and skin of color. So tune in for that one as well to finish out our season. And always, Bill would encourage me to remind you to sign up for AFC Annual Fall Conference, which will be November 7th through 9th in Kansas City this year for the first time in a while. It's going to be having an optional interactive procedures workshop. This year will be OMT for all physicians. That happens on Thursday, followed by the weekend activities. So it's going to be hosted at Intercontinental on the Plaza. Registration is open. So if you love in-person CME and shopping on the Plaza and nice Kansas City afternoons, we are also going to be getting dressed up for a themed gala. So it's Roaring 20s this year. And there's going to be a really great silent auction for some prizes to win. So register when you can. We look forward to seeing everybody in Kansas City. And without further ado, please welcome Dr. Kate Lichtenberg.
Thanks, Lauren. I'm happy to see everyone tonight. By way of introduction, so I am a past president of MAFP, and yes, the plug for AFC, definitely everyone should plan to attend. I spent 11 years, just over 11 years, working at Blue Cross Blue Shield after 12 years in clinical practice, and I moved to Anthem to roll out their value-based programs in 2013. So I started with commercial programs and then moved on to Medicare Advantage and finally into Medicaid in 2001. So I'm going to keep it at a somewhat high level because I know the most about what has happened at Anthem, but you'll see more and more value-based programs popping up. So I have not shared on Zoom before, so bear with me for just a moment while I pull up the slides. Somehow I've managed to pull up another window. Here we go. Okay, and hopefully everyone can see my screen. All right. Okay, so disclosures. I have nothing to disclose, although I have worked for Anthem. My position actually was eliminated a couple of months ago, so I am currently on the search for my next adventure, but nothing to disclose. The learning
Dr. Lichtenberg, your slides are not advancing on our side, and it's not in the slideshow, so I don't know if it's on a different.
Okay, let me go back because let's see. Thank you, Bill, for pointing that out. So I had put it to slideshow, but it's not showing slideshow on your end still, correct?
Correct.
Okay.
So it could be on another screen. If you hit the green share button, you may just need to share it through the PowerPoint application instead of the window itself or something.
Okay. Let me try this again. I love technology. Okay, can you at least see the slides now?
We can, yes.
Okay, and if I do this, did
Yeah.
that go? It went to, okay,
that
all
works.
right. Okay, thank you. Okay, so we'll go to the learning objectives. So I'm going to spend a little bit of time talking about the evolution of health insurance in the US. It's actually really interesting, and I did some research on this for another talk I gave a couple of years ago. We'll spend a little bit of time talking about the different reimbursement payment types, and talk about the HEDIS measures, or the quality measures, that family physicians are most likely to be measured against. That is probably one of the most common questions I get from folks that I have worked with, is why these measures, and what about them makes them special. So talking about the history of health insurance in the US, even before workers' compensation insurance back in 1915, I came across some information from Mark Twain, of all people. In one of his biographies, he talked about how his family paid their local family physician $25 for the year to cover any and all health issues that his family may have had. So you could potentially say that that was the first instance of direct primary care, or capitation, depending on how you want to look at it. And back at the turn of the century, not 2000, but back around 1900, the concern was more for lost wages, not so much for paying for the actual medical care. And so that's where the workers' compensation insurance started around 1915. Hospital insurance came about in the 1930s during the Depression, and Blue Cross actually started as insurance for hospitalizations. It only covered inpatient, nothing still for physician coverage. And so Blue Shield came a few years later, and that was actually because some teachers' unions were looking for coverage. Interesting to note, because we hear so much about national health insurance right now, the AMA was adamantly opposed to this in the 30s and 40s, and so it kind of died at that point. Those in government that were trying to prop this up thought, well, we'll just wait and it'll come back up, but it really didn't for several years. And then there's also a lot of talk these days about employer-sponsored insurance, and that really started to come about after World War II as a benefit. So salaries, wages were kind of standardized at that time, when when women were entering the workforce, when men were coming back from war, and there was stiff competition for new workers. And so this was one way that employers were able to pull some of those folks in, is by offering health insurance. And we can spend a lot of time talking about whether or not that's a good thing and whether it should be decoupled, but that is where it first came about. Medicare and Medicaid, as you all know, was signed into law in 1965. I went and did a little bit more reading about the direct primary care model, and that actually first started coming about in the late 1990s, but we didn't start hearing about it until into the early 2000s. And I just saw AAFP talking about how they're now entering their second decade of supporting DPC practices with their toolkits and whatnot. Medicare Part C, also known as Medicare Advantage, became effective in 1999, and Part D for medications followed in 2006. And then, of course, we have Obamacare, the Patient Protection and Affordable Care Act that became effective in 2014. So here are all the different ways that physicians can be paid in different manners, but I don't have to spend time talking to you all about the hamster wheel of fee for service. But talking more about those reimbursement types, so most folks are familiar with fee for service. Pay for performance, that was actually MIPS that first came about in 10 or so years ago, where you're paying for gaps closed. Value-based payments, including shared savings, and that can include what's referred to often as upside and downside risk. Obviously, there's no risk on the upside, so you're only looking at getting the positives without taking on responsibility for any negatives. Bundled payments, we see those more in the specialty space. So think about things like colonoscopies, hip replacement, knee replacement. I'm now seeing bundled payments for bypass surgery, OBGYN, so lots of bundled payments coming about. Capitation, and this is different from the capitation of the 80s. I know there's probably some folks that do remember that, but capitation is both the payers and the providers have become a lot more savvy when it comes to capitation. I can tell you that Missouri does tend to be a laggard. So when I was working at Anthem, we talked to several groups about capitation. Nobody was interested. And I had a really hard time explaining to our corporate offices that we're in the middle of the country. We don't do things nearly as fast as the coasts do. And so when I left Anthem a month ago, we still had no one who was willing to engage in a capitation model. Prospective payments, this is where money would be set aside up front for, it's similar to bundles, but it's used in the primary care setting. So you might get that money up front and then you're taking care of an entire episode. Direct primary care, I don't think there's anybody on the call, I could be wrong, who does direct primary care, but I think most people have heard enough about it now, where and some people will conflate that with concierge care. There are differences there. So concierge does tend to be quite a bit more expensive. There are a lot of things that do overlap both of those, though. So it tends to be much smaller panels. There is a fee of some sort. And then you are typically, most folks, the practices are capped around 400, maybe 600. And so it's supposed to be easier to get appointments with your physician. You get to spend more time with your physician. You still typically have other health insurance that is covering things like your prescription medications, or if you need any type of ancillary services, or if you need to see a specialist. Some bigger direct primary care practices will have some of that on site, so they may dispense their own generic medication. So it really depends on who you're seeing and what services they offer. Concierge care, I know often the specialist will accompany their patient to a specialty visit. So the primary care will accompany them to a sorry, let me back up a moment. The primary care physician will accompany their patient to a specialist to help make sure that everything is being covered, that their patient understands what's going on. Interestingly, I have seen some specific pediatric concierge care where they do all home visits. So I think the sky really is the limit on what you can do with that particular model. So where did all of this value-based payment come from? The Center for Medicare and Medicaid Innovation, or CMMI, also known as the CMS Innovation Center. So that was established by Congress in 2010, and I had the good fortune to work with several folks who worked at CMMI and then came over to Anthem. So the whole idea was to improve care, lower costs, um, better align payment systems to promote patient-centered practices. When I first got into this, there was a big push to get as many practices as possible to adopt the NCQA patient-centered medical home process to actually get that certification. And what we found out over time is that well, first, it was expensive. And second, it was a lot of box checking. And we found that a lot of times there weren't true changes made within practices, or maybe only one or two. And so eventually Anthem adopted the stance of, we would like for you to have PCMH certification, but it's not required. I always kind of took the approach of maybe you take 2 or 3 of the tenets of a patient-centered medical home and really work to implement those. And that worked out pretty well for the practices that I worked with. But a lot of this all came out of the Innovation Center. Alternative payment models, or APMs, people may be familiar with those, also developed and tested. This is where MIPS came in, bundled payments, programs for specific health conditions like end-stage renal disease. And I can tell you, there have been far more programs that have been dumped than have actually been implemented on a broader scale. For the folks that are in the Kansas City area, you may be familiar with CPC or CPC Plus. That was a multi-payer initiative that was brought about by CMS. Anthem on the eastern side of the state, most of the state, we applied to be a part of CPC and were not chosen, but Blue Cross Blue Shield of Kansas City was. And so that area became, they all participated in a multi-payer program to try and get these APMs implemented. So I'll be curious to hear at the end if anyone's practice was maybe involved with that. And it was interesting to see the results. There were areas around the country that saw significant savings with the support they were getting. There were others that did not move along as well. So it was interesting to follow that over the period of about 6 years. Missouri did have the entire state had a multi-payer program. It would have been around 2013. It was right around the time that I had started with Anthem. Anthem was working with Missouri Health Net, so with Medicaid, and there were at least a couple of other private payers who were also participating, so that it was a medical home concept, but it was really starting to die out by 2013. But there have been no other multi-payer programs since then. Because when you think about it, and this is one of the big issues, if every payer has a different value-based program for you to participate in, it becomes very difficult to keep track of what you need to do for each, and do the measures all line up? And I'll talk a little bit more about that. Whereas with these multi-payer initiatives, everyone was on the same page. So you might be participating in a program that involved 4 or 5 different payers, and it was the same rules for all of them, which I really think is the way to go. But unfortunately, they're much more difficult to administer. So a little bit about the Healthcare Payment Learning and Action Network, or HCP LAN. This is probably not something that most of your practices would need to know about. Now, for folks who are working for larger health systems, you likely have entire departments that are managing your value-based programs. So I can tell you for the big hospital systems in the state, so think Mercy, SSM, BJC, Cox. And the one thing to keep in mind, I'm not ignoring my friends in the Kansas City area, but from a commercial standpoint, commercial and Medicare Advantage, we did not cover that service area. I did with Medicaid, but for commercial and Medicare, that would be Blue Cross Blue Shield of Kansas City. And I know they had some of their own programs as well. But this is kind of what I lived and died by, is what kind of programs we were offering. Medicare, and I'm going to actually jump to this next slide for a second and then go back. Medicare or CMS has a goal that, for example, by 2024, by this year, 25% of Medicaid and commercial payments would be through a Category 3B or Category 4 program. And we'll go back in a second and go through what those are. But this is just so you can get an idea, because the numbers were much higher for Medicare Advantage and traditional Medicare. So this is how the payers are looking at, and for anybody whose organization is in an MSSP, that would encompass your traditional Medicare. But Category 1 is simply fee for service. There's no link to quality. There's no link to value. This is just how we're used to being paid most typically. When we get into the Category 2 programs, those are fee for service, but they have a link to quality and value. And so the pay for reporting, so again, like MIPS, that would be considered a Category 2B. 2A would be foundational payments for infrastructure and operations. So this could be a care coordination payment. So let's say that, okay, I am going to give Practice X $3 per member per month so that they can start implementing quality improvement programs. And they would not have to report back to me any improvements they made. We're just going to give them a set amount of dollars each month so that they can invest in additional technology, staff, whatever they might need to improve quality. Pay for reporting, and then pay for performance, so a 2C. For anyone who may have been taking Healthy Blue, I can tell you that up through 2023, they had a pay for performance program that was paid out each year, bonuses. So if you happen to have a Healthy Blue member that had an open gap in care that you closed, and you may not have even known that it was on a list anywhere, but you would get payment the following year for having closed those gaps. So it was, I had groups that would contact me and ask me what a check was for because they didn't know. So I guess that's nice when, sometimes you get some unexpected money, but that was a pay for performance program. We sunset that at the end of 23 because we had more robust programs to move folks into. So this is where I was talking before about the categories 3 and 4. So category 3, an alternative payment model built on a fee for service architecture. Basically, you're still getting fee for service, but what can we place on top of it so that we're promoting the increased quality and trying to decrease those costs? So shared savings would be a 3A. So for example, we offered a medical cost performance program for our primary care practices, and you would get a care coordination payment each month, and then we would track your medical cost compared to historical costs. And at the end of the measurement period, if you came in under the target we set based on historical performance, you got a portion of that shared savings. The big push has been moving to shared savings with downside risk. And I can tell you that from my standpoint at a private payer, there was a huge push. There were commitments made to Wall Street. And again, we could talk about for-profit insurance at a different time, but promises made to get more groups to take downside risk. And I had lots of conversations with folks about this that were practicing medicine, because practices weren't designed to take risk, right? That's what the insurance companies do. They have the actuaries to figure out what the risk is. but this could be an episode-based payment for a procedure, so a bundle that has downside risk. So if the group ends up spending, or let's say it's a total hip replacement, and Anthem is going to pay the surgeon or the hospital $15,000 for that. So that would, and I'm making these numbers up because I honestly don't know how much a hip replacement costs at this time, but that would be everything from the initial consult to the actual surgery, including whatever implants are used. It would be the follow-up, the physical therapy and follow-up, any complications that might occur. Everything would have to be done for that $15,000. If they did it for 10, well, then they have an extra $5,000 that they just made. If the patient has a complication and it ends up being $30,000, well, the practice is now out that additional $15,000. So the incentive is supposed to be you manage them tightly, you do everything you can to decrease the risk of any sort of complication, so that at the end of the day you can end up with additional funds. From a primary care perspective, this would be same thing. So you have your panel of patients that you're caring for. We look at what your historical costs had been, and if you did better than historical plus trend, you got a portion of shared savings. That was how the commercial side looked. For Medicare and Medicaid, we used an MLR, a medical loss ratio calculation. And so typically 85% of the premium dollar, if you're spending less than 85% of the premium dollar, you would get a portion of anything left over, or you could end up owing. I'm happy to say that I had very few practices during my time that ever needed to write a check. Most of them actually were very successful. And then category 4, this is where we get to the population-based payments. So I actually only had one group that was in a category 4, and they were actually a 4C, so an integrated finance and delivery system. It was a global budget. So they got, I guess, the capitation. So I misspoke earlier when I said no one was in capitation in Missouri. In the Kansas City area, Children's Mercy has a network, and they are total capitation for that. So, and they do very well. So they're given X number of dollars per the members assigned to them per month, and that is what they get to manage that Medicaid population. Global budgets or fuller percent of premium payments, 4B, and then 4A, the condition specific population based payment. From a private payer standpoint, we did not have a lot of programs that met the category 4 criteria that we could offer. It was interesting that for certain groups that were ready to take risk, we came up with some very unique and novel programs for them. But in Missouri, and this is where I would tell people that we are the show me state for a reason, that we want other folks to show us that that you can be successful participating in these. And so I didn't push hard on category 4, but this really, if you ever hear about the HCP LAN or the LAN categories, this is what is being referred to. And then to look a little bit more at this, so 24, I don't think we are going to meet the goals that CMS had set, at least for, actually, I don't know that we're going to meet any of them. In 25, they go up, and by 2030, 100%, so all Medicare would be in some type of, being paid in some type of alternative payment methodology, which is a little bit scary to think about. That's a big change. It's a very different way of doing things. And then when you think about the lack of primary care, or how we're losing doctors, we don't have enough doctors. how we're going to manage all this will be interesting. But this is the current set of goals. AEFP is very involved in this. There is an entire department that works on this. I sat on the Commission for Quality and Practice from 2015 to 2020, and we talked about this all the time. We looked at different alternative payment models, at how physicians could be successful in this. So do know that the Academy, excuse me, is doing a lot of work to make sure that family docs are ready. There are some toolkits for this so that we can be, as successful as this continues to ramp up. So a little bit more about medical loss ratio. I say we, so the insurance company in the case of Medicare Advantage or Medicaid gets a percentage of the premium, or it gets the premium each month. And so when we're calculating the medical loss ratio, it's the percentage of the premium that the insurer spends on medical care and performance improvement activities. We could again spend a lot of time talking about if 85% is what we're wanting to see spent on the patients, where is that other 15%? And of course, some of that, it probably more than what it should be, is overhead, along with dollars for the insurer. There's actually a resolution coming up at the House of Delegates next week about should the Academy push for the end of Medicare Advantage? Should we get rid of Medicare Part C? And it was interesting to look at the staff background on that, because it was thought to be politically high risk because seniors love it. They get many more benefits than what they get in traditional Medicare. And so as much as it is a pain, and with all of the hoops that you continue to have to jump through for things like prior authorization, I don't see that it's going to be going anywhere anytime soon. So, for example, if 80 cents of the premium dollar is spent on care and performance improvement activities, then the medical loss ratio would be 80%. For Anthem's Medicare Advantage programs, the targets were set somewhere between 83 and 85%. And so we were looking for groups to spend no more than that. So let's say you spent 80 cents on the dollar and your target was 85. Well, that 5% difference then would be what is funding a shared savings pool. At what point does this become a problem that care is being withheld to meet these? We had quality minimum quality targets, and so if you did not meet minimum quality, it didn't matter how much money you saved. You would not see a penny of that. And so that is how we got around that possibility that there would be a practice who would withhold care in order to keep the costs down. For Mo Health Net, what was interesting is that they wanted to see a year-over-year improvement. And it was interesting to see when the public health emergency was still going on, and there were lots of people on the rolls who maybe had then gone and gotten a job and were no longer using their Medicaid benefits. They were contributing $0 to to spend. So we saw very low medical loss ratios, because you could have a quarter of your panel that we weren't spending any money on simply because they had another source of insurance. So as redetermination has gone through over the last year and a half, and those folks are falling off the rolls, the MLRs are going way up. And so it's been interesting to watch the groups that have participated in our shared savings model. They have seen their MLR go from maybe upper 70s to upper 80s. And so it's almost kind of like a reset now that we're getting back to what the panel truly is. and it's going to take some time for that to all reset. I think we had 100% of our participating groups that got shared savings in 2022, and no one achieved shared savings in 2023. And that in large part is due to that redetermination. So that's how an MLR program would work. Quality measures. So HEDIS is the end all be all, the healthcare effectiveness data and information set. And this comes from NCQA, the National Committee for Quality Assurance. I'm guessing that some of your practices probably have some type of NCQA accreditation, maybe for heart stroke or for diabetes. So they set up these measures. They do have stewards. So they are nationally known and they get approval. So it had been the National Quality Forum that would approve these measures. There was a change in the vendor at the end of last year, and it's no longer NQF, and I cannot remember the name of the new group off the top of my head. But if anyone is really interested in quality measures, AAFP does have designated volunteer physicians who sit on these different committees. I sat on the committee, the standing committee for geriatrics and palliative care for 5 years. So any measure that NCQA was looking at, or maybe another organization was looking to get approval, because that's really what you need in order for these to be incorporated. If you have interest, you can apply to be on one of those committees. Currently within HEDIS, there are more than 90 measures across these 6 domains that I have listed here. Most programs, they do not have 90 measures because there's no way that you could keep track of all of those. Even 15 is a lot of measures. I can tell you when I started at Anthem on our commercial side, we had 30, and it was very difficult. It took a long time for me to convince folks that the physicians are going to concentrate on just a handful of those. And so there was a concerted effort over several years to cut the number of measures down. And at the time of my departure, we were down to 15 measures on the commercial scorecard. Medicare was a little bit different. That did tend to be a few more. And that's when you get into things like double and triple weighted measures, where it's going to have a more profound impact on your overall score. These are national performance statistics and benchmarks. It's interesting, when I sat on the Commission for Quality and Practice, there was a lot of discussion at one of our cluster meetings about the letters that insurance carriers would send out to say your patient is due for a mammogram and a colonoscopy and a hemoglobin A1C. And why do the insurance companies waste our time with that? Well, the insurance companies actually also get NCQA certification, and that is something that is required by NCQA. I'm not saying that it is appropriate or it should be done. It's just sort of a fact. So the commercial data that is collected from insurance companies, so for example, if you wanted to know what the mammography rate was for all of the commercial payers in the state of Missouri, you could go to the Quality Compass. The only caveat to that is the health plan has to agree to allow that information to be published. Anthem was allowing that. I think most of the insurance companies are. But if you wanted to see how the different insurers were performing on the different quality measures, you can go access that. So you can see health plans, purchasers, consultants, media. You can all go in and look to see how does Anthem compare to United or to Aetna. So and you can actually see a lot of information just by going to NCQA's website. So if anybody is dying to know more, ncqa.org is where you can go for that. There had been a very concerted effort back in 2015 to 2017 to try and get core measures, because what Aetna had for their diabetic measure might differ just a little bit from what Anthem has, and might differ a little bit more from what United has. And so trying to keep track of who wants what for what measure really became difficult. And so AHIP, the insurance uh, trade association, brought together all kinds of folks to try and put together core measure sets. There was the Core Quality Measure Collaborative. I actually participated as the AAFP representative on that for a few years as well, trying to get cross-payer measurement alignment, also known as harmonization. In 2017, they came out with their first set of core measures. I was so excited. I think I was actually in Jefferson City on that day that the news broke for an advocacy day. And I was so excited because I thought this is going to be, and I know the things that excite me probably don't excite most of you, but I thought, oh, finally we can, take this out to folks and say, here's one measure set. This is what it's going to be. Anthem refused to adopt it. I don't know that any insurance companies adopted it. And that was really too bad, because there had been a lot of work that went into this. And to this day, there is still, there are core measure sets around. There's one for adults, there's one for peds. There are some for specialists, especially OBGYN, cardiology, and GI, I think. And they've really not been adopted. So AAFP does continue to participate. I just saw an email last week about needing a vote from AAFP on the latest set of measures that are looking to be approved. So once again, know that your academy is involved, but then getting the payers to move forward with it is really challenging. I don't think any of these will be a surprise to you, but breast, cervical, colorectal cancer screening. What has been difficult in the past is that, like when I first rolled out my program, it was claims based only. And so typically if somebody's getting a breast, a mammogram or a pap smear done, there's a decent chance we can do the look back to see, okay, did they have a mammogram 2 years ago? Are they consistent with how they should be doing this? Colorectal cancer screening was a lot more difficult, because if someone had a colonoscopy and didn't need to come back for 10 years, the odds of them being with the same insurance carrier for 10 years was pretty low. And at least initially, we weren't able to do a 10-year look back to go, back that far in our claims history to see when they were due. And so a lot of these gaps were showing as open when docs were saying, I did this. Hey, I actually have the copy of the last colonoscopy. Can I send it to you? Well, that's kind of another whole can of worms, because being able to send in additional clinical data and have it incorporated was something that we're still not very good at doing for the commercial side. We're doing better for Medicare, but the resources that the payers are putting into being able to take in supplemental data really varies. And there was a resolution, I think it's actually come up a couple of times in the last maybe 5 to 7 years, where it was asking AAFP to plead with the big six insurers to take supplemental data for these value-based programs. It's difficult. They can certainly have those conversations, because AAFP does meet with all of the big insurers and CMS every year, but pleading with them to do it and actually getting them to do it are two different things. So that continues to be a challenge. Child and adolescent immunizations, these are composite measures. When I was on the Commission for Quality and Practice, we were very much opposed, and we had a position paper on quality metrics. We were very much opposed to composite measures. So what that means for the childhood immunizations, it's combo 10. So there are 10 different immunizations that need to be given at the designated times in order to get credit for that measure. So it's not that you finally got them all done. It's that you delivered them at 2 months, 4 months, 12 months, whatever their dates are that they were due, and you had to get all 10 of them in order to get credit for that measure. That's really hard, especially in today's environment when sometimes you're just trying to get a parent to accept one vaccine, let alone getting all 10 done on the recommended schedule. I'm not saying that we shouldn't be trying to do that. And I think every vaccine given should be considered a win. But in this case, and this I can tell you, Mo Health Net has Combo 10. They have the adolescent is 2 vaccines. It's HPV and meningitis. And again, we all know how easy it is to give those vaccines when parents are hesitant. So I'm not a huge fan of composite measures. I argued against them frequently, but that is a battle that I did not win. It'll be interesting to see how that goes in the future. Asthma medication ratio, this is looking at how many rescue inhalers someone is being given. That can be a tough one, and this is for both adult and peds. This can be tough because when you're talking about kids, maybe they have one at home, one at school. If the parents have split up, they have one at mom's, one at dad's, one at school. And that blows your ability to keep within that ratio, because the whole idea is that you're limiting the amount of rescue inhaler a child is using. It has been a frustrating measure to work with folks on. But we continue to look at how we can improve it within the practices, but also how can we intercede with NCQA to make this a more reasonable measure. And there are opportunities for public comment when they're looking at new measures. I know that that's the last thing that we all need to be doing in busy days, but AAFP does also do that on our behalf, is often submit testimony or written feedback for the potential new measures. Controlling high blood pressure, this is one where we really do have to have supplemental data. And for, I think for most insurance companies, collecting supplemental data for Medicare is pretty standard. If you, again, work for a bigger health system, that is something likely happening behind the scenes that you may not be aware of. If you're a smaller practice, I can tell you that Anthem had folks in the field that would work to help groups set up feeds from their electronic health record. But it's difficult, especially when you have a small staff. So that does make it harder for smaller practices to participate. Eye exam for patients with diabetes, hemoglobin A1C control, the kidney health evaluation, that actually, the technical specifications for that recently changed. And I had a group that I worked with. It was a smaller health system, but the primary care docs were very concerned about the new measure, even though we had told them that it was coming from NCQA, and said they would not put that into their patient process for doing things until they had cleared it with their nephrologists. So that's the other difficult thing, is that there can be small tweaks to how these look year to year, and that can sometimes, unfortunately, lead to needing to make some pretty big changes into your process flows for your patients. Osteoporosis testing and management, prenatal postpartum care. This is another one. It's hard because when you don't do prenatal care, and let's just say you're seeing patients once a year for a physical, you could potentially have a patient who gets pregnant and delivers their child between visits to you. And yet you're potentially being asked to make sure that they have prenatal care within the first 12 weeks and that they have their postpartum visit within 6 weeks of delivery. And I just realized the time, and I was afraid I wouldn't have enough to talk about, but obviously I could talk about a lot of this for hours. Chlamydia screening in women, and in this case, the technical specification is age 16 to 24. And if someone is on birth control for any reason, that they are considered in the denominator, that they should have chlamydia screening, even though they may be taking it for reasons other than contraception. This is the HEDIS measure. This is what NCQA has come out with. I can tell you though, the benchmarks for this are around 45%. So there is acknowledgement that not every woman truly needs it. And what I had told the docs that I worked with is that I don't ever want you to do a test that is not appropriate for your patient, but this is what the measure is. But we're not looking for 100% compliance. And I got the most pushback from pediatricians. So not surprising, but everybody was concerned about that. But, you know, chlamydia, especially for example, in the St. Louis area, there's a lot of chlamydia. We need to do a better job at screening for it. So just these are kind of the pitfalls with some of these. Cut points real quick. They're updated each October and they reflect the prior year's performance. So, and the cut, so with stars, you're graded at 1, 2, 3, 4, or 5 stars. The cut points that will be coming out next month will be for the performance of 2023. And so, you know, throughout the whole of 2024, you are being compared against the 2022 performance. So there's true ups. It can cause delays in payments, health plans. And I can tell you Anthem did this for a while, did internally derived cut points. It can be confusing. You also have to keep track of whether or not there are measures that might be information only. But if they're information only this year, there's a good chance that that may be a measure that you'll be held to for any type of compensation the following year. I've alluded to the fact that larger physician groups and hospital-owned groups often have huge teams that work on this. They may have nurses, health coaches, data analysts, quality improvement specialists, pharmacists. I work with several groups that had a full-time pharmacist working on this. And that's great when you work for a big system, but how in the world can small practices even begin to participate in programs like this when they have such small staff? And that's where aggregators come in. Currently in Missouri, Aledade and Main Street Health are the only 2 aggregators that are recruiting practices. But basically, they are going to smaller practices and saying, hey, come join our ACO, and we will help you with all of these things that larger practices have. Privia and Agilon, they are still mostly on the East Coast. They haven't gotten much past Ohio, I think. Main Street Health actually focuses on Medicare in rural practices, and they actually bring in health coaches from the community to help. It's a really neat concept. I can tell you that we had maybe 15 practices that I worked with that had joined Main Street Health, Medicare only though. Aledade does Medicare and commercial. And then Diverge Health is one of some new growing aggregators that focus on Medicaid. We had been having some conversations with them before I left. It's hard though, because you don't want to end up working with 3 different aggregators based on your different lines of business. So it will be nice when there is, for smaller practices, when there is one group that they can maybe work with to get some help. I do have some references here if you want to go read anything else. But I did want to leave a few minutes for questions if anyone has any. I've either put everybody to sleep or you now know everything you could possibly want to know about value-based care. One thing I did not mention was attribution, which is really the foundation of value-based programs, is who are you responsible for? Whoever comes up with a good way to make sure that attribution is done and done well will be able to retire probably the next day. You can have people choosing their own PCP, but if they then change and go to someone else, but don't change it within their insurer system, you're still going to be responsible for them. At least that's how we saw it. We also used visit-based attribution. So we would look at the previous 2 years and see who someone was seeing as a primary care doc. That worked well until they started moving around, and there was a whole algorithm for that. If anybody is interested in talking more about attribution, I would be happy. CPC Plus, Comprehensive Primary Care and Comprehensive Primary Care Plus. So CPC was the first. So it was a demonstration project that lasted for 2 years. It was doing relatively well, and so when they renewed it, they called it CPC Plus. But Comprehensive Primary Care, MSSP, that's bad because that one just fell out of my brain. But I will follow up with you and let you know what that acronym is. And it's another whole set of acronyms that you deal with when you get into some of these things. I didn't see if there were other questions in the chat.
I think those were all the questions so far.
Okay.
Are there any other questions? Okay, just a reminder that Bill just dropped the link for the CME reporting. So be sure to click on that or the one in your reminder email from today to claim your CME. And if there are no further questions, we will thank Dr. Lichtenberg for her time, and I hope to see you all next month.